evening. First of all, thank you very much. Thank you very much for coming on Wednesday evening. Thank you very much to the college. Wendy, thank you for giving me what is an unusually generous amount of time. You'll be depressed to hear. And not only that, but a tremendous amount of time and virtually no scrutiny over what I was actually going to do with that time. So it reminds me of how psychiatry used to be. On May the 8th, 1885, a 22-year-old barmaid from Bristol, called Sarah Ann Henley, jumped from the Clifton Suspension Bridge to a drop of 250 feet. She had just the day before got a letter from her fiancé breaking off their engagement after a row at his work. The local Bristol paper, which is it's called the Bristol Magpie, reported the next day that the wind was strong that day and caught in her clothes, so that she effectively formed a petticoat parachute and drifted towards the ground. And it also blew her off course, so she landed not in the river, but in the soft mud on the Gloucestershire side. The paper referred to the incident as this rash act, and it depicted what had happened with an artist's impression of how she jumped. Now, what happened was that two men pulled her out of the mud, and what was referred to in the press as a passing doctor called for her to be taken to hospital. She was the first person to survive a jump from the Clifton Bridge. Another man, the paper referred to only as a detective, tried to pay a cab driver to convey her, and the cab driver refused on the grounds that his cab had just been cleaned, which was very muddy. And he was reported as having said, "Let her die." So Sarah Ann Henley, she was badly injured, but she survived, and in time she married, though not the same person, somebody else, and she lived into her 80s, until 1948 in fact, 63 years later. So it's a story with quite a lot of modern echoes. First of all, the bridge in Clifton, I suppose, still one of the country's most notorious suicide hotspots, although almost every area has one. The detailed media reporting of suicide and suicide method, and its apparent justification, the broken relationship. The final straw, the life event that acts as a trigger. And even now, relationship breakup is still, in most studies, the most common final straw. The ambivalent public reaction, the concern from some people, and apparent callousness from others. But is it callousness? Or is it telling us something wider about social attitudes to suicide and to suicidal people? But most of all, it's a positive story about prevention, about getting through the suicidal moment. It says there's no inevitability about suicide, even in people who are highly suicidal. A suicidal decision on one day may not happen again for another 63 years. The WHO publishes suicide statistics from around the world, and the story is one of variation. This is a map taken from the World Health Organization. So a story of variation. The WHO says that there are 800,000 suicides a year worldwide, although that's almost certainly an underestimate. Although most people believe that suicide is a problem of the developed world, that in fact is not true. It is numerically more common in low-income and middle-income countries. 75% of suicides worldwide are in poorer countries, where the average age of death is 20, compared to the richer countries where the average age of death is 50. It is not a first world problem, not just a first world problem. The highest rates in the world are in quite diverse places. On this map, the highest rates in the world are in South Korea, in Guyana, in Lithuania, and until recently, in Sri Lanka. 4 very different countries. And it tells you that suicide is not one thing, and that suicide prevention too is not one thing. Variation and diversity. Around the world, the commonest methods of suicide are pesticides and hanging and firearms. In the United States, 50% of suicides are by firearms, 20,000 people, 20,000 deaths. In this country, the figure is 2%. Variation too in the United Kingdom. Across the UK countries, England has the lowest suicide rate. The rate in Northern Ireland is 70% higher. And even within England, quite a lot of variation. Again, another of these colour-coded maps. Dark colours are high rates, pale colours are low rates. So variation, but it's not random variation. The highest rates are in the north and in the southwest. And in some of the coastal areas, like Norfolk and the south coast. These geographical divisions, by the way, are the STPs, the currently fashionable, soon-to-be unfashionable NHS regions. And the lowest rates are in London, the only part of the United Kingdom where the suicide rate did not go up after the 2008 recession, and in the adjacent parts of the home counties, the richer parts of the country. Where George Orwell famously said that you can hardly throw a half brick without hitting the niece of a bishop. So low rates in economically powerful parts of the country. So suicide variation, much of it driven by deprivation. And variation too over time. So this is the suicide rate in England over the last 15 years or so. And the blue line is the all persons rate, so that's standardized rates for the population as a whole. And what it shows on the left-hand side of the graph, on the left-hand side is it's essentially the tail end of a 30-year process in which suicide rates have been falling in this country, leading to this point here, around about 2006-7, which is the lowest suicide rate on record for England. And records began in 1861. But, and there is always a but in suicide statistics, the suicide rate then began to rise, sort of unexpectedly, as a result of the worldwide recession, the downturn in the worldwide economy. So a maddening event that when we got to the lowest rate ever in England, that reckless selling of subprime mortgages in the American Midwest tracked its way through to the estates, coastal towns in this country and the survival of vulnerable people. But that's what happened. It may not look like very much, but that is an extra 700 deaths per year in England. And only now are we seeing the tail end of that recession-related rise, several years after it happened. Unemployment, of course, began to improve long before this, and our fear for the impact of the economy is that it's changed. It used to be that you could almost measure the suicide rate indirectly by the unemployment rate. The two were so closely related. But now we talk not just about unemployment, but about low-income jobs, about zero-hours contracts, about job opportunities and pressure and insecurity in the workplace and in people's homes, people's households. That's what the economic factors are. So the new unemployment in suicide statistics is these other economic factors, and with low growth forecast for the next decade, the fear is that the impact on suicide will persist. So again, a story of economic factors, of deprivation affecting vulnerable people. But deprivation is not something that is so enduring and ingrained that you can do nothing about it. So this slide is actually slightly different. This is a slide from some people who work in my unit, Pearl Mock and Roger Webb, And they're looking at self-harm, not suicide, and they're doing it in Denmark with these fantastic case registers that we've been plundering for the last 20 years. And it's the purpose of the study was to look at self-harm rates in the young people in families according to income. So divided the Danish population according to their income and then checked self-harm rates in relation to it. But it checked income at two different time points, at the time of birth of the young person and the time when they were 15, to give an idea of trajectory. So here, this is the most affluent group, children in the families that were most affluent, so the richest group who stayed rich. And we call that reference point 1, so just for the purpose of comparison, their suicide rate becomes 1, self-harm rate. And here at the bottom, this is the opposite. These are the people who start off poor and stay poor, and their self-harm rate is 6 times higher than the economically advantaged group. But most interesting is the socially mobile group, social mobility in the news at the weekend. Socially mobile group, those who went from poor to rich, their self-harm risk dropped by about 2/3 compared to those who stayed poor. And it was roughly the same as those who started rich and became poor. So social mobility, upward or downward, is a profound influence on risk of self-harm and by implication suicide, and therefore remedial. And variation too by age and gender. So this is a typical age and gender graph showing, first of all, that the male rate is 3 times higher, but that's not uniform. The male rate are the blue lines. That the rate is highest in middle-aged men, probably driven by alcohol and debt and untreated depression. And I suppose most people know that middle-aged men have a high rate of suicide. But what's less well known, one of the things that we don't consider so much when we think of high risk, is the risk in this this older group, that men in their 80s also have a comparably high rate. And what kind of society are we in where men in their 80s have one of the highest suicide rates of any demographic group, probably driven by bereavement and isolation and physical illness? But more generally, what is it? Why men? What is it about men? Why is it? This is one of the most murderous chemicals known to man. It's the DNA of the Y chromosome. It is nature's ball and chain, bringing with it high rates of most of the main causes of mortality, including suicide. Why is that? Well, first of all, men have more risk factors, unemployment, alcohol, but also they're probably more affected by those risk factors. Secondly, they have certain psychological characteristics that make them vulnerable, so it being impulsive in a crisis, a proneness to humiliation, incredibly powerful, destructive emotion, humiliation. When they get into crisis, they tend to use more dangerous methods of self-harm, more likely to have a fatal outcome. And they're not so good at seeking help. About 1/3 of people who die by suicide have not seen their GP in the previous year. They're not in contact with any health service. And most of those people are young and middle-aged, and they're men. Now that's different from saying that suicide is related to talking. The media story out there is one of talking. You cannot get away from the idea that the solution to the male suicide problem is that men should talk more. And it sometimes seems that that simplified message, that's so popular with the media, has overshadowed any other explanation of why suicide occurs in men. And I have to say, I meet a lot of people who've been through suicidal period in their lives, and when you hear the testimony, the personal narrative of a man who has finally, after a lot of stresses, unburdened himself and felt better of it, felt less suicidal. It is a very powerful story. It's an incredibly powerful story. I've met a lot of people who tell that story. But there is a law of unintended consequence here. The law of unintended consequence, the one law that no government could ever repeal. The law of unintended consequence is that personal narrative has become so popular, that narrative of talking or not talking, has become so powerful that it has overshadowed everything else in the public discourse about suicide. And that has let society off the hook of doing more about poverty and child abuse and offenders and drugs. And it's let governments off the hook too, recognising that no wonder governments like to tell the story of talking, because otherwise they have to deal with the other causes, the deprivation and other things. There are 200 people with schizophrenia in this country who kill themselves every year, and most of them are men. And their problem is not talking. Their problem is the care that they receive. So not talking is an overplayed story. So preventing suicide is tackling all of those things. Preventing suicide is also knowing who's at risk. Now, there's a common idea around that certain occupations are at higher risk than others, and most people believe that doctors are at high risk. In this country, that's not true. Doctors are not at high risk. In fact, male doctors are at low risk. That's different in other countries, but in this country, doctors are not at high risk. Most people believe that ex-servicemen are at high risk, but in this country, that's not true, or at least not overall, although there is a group, young army ex-servicemen, been in the army for a relatively short time, that does have a high risk, but overall, that's not the case. So who are the high-risk occupations? Well, you can read this, they're the groups like people who are unskilled, relatively uneducated, poorly skilled, people who work in the construction industry, builders, people who work in agriculture, not farmers particularly, but people who work at lower levels in agriculture. Those are the high-risk people whose suicide prevention has to be designed around. And suicide prevention is also about reducing access to means. One of the most important ways of reducing suicide is to stop people getting hold of the method that they might use. So you know about the restriction on buying paracetamol over the counter. That's an attempt to restrict access. You're bound to know about the famous coal gas story, the supply of gas to Britain's kitchens that was changed to something less toxic. You may know about the way in which car exhaust asphyxiation became almost unknown in this country, and that was thanks to the EU. It was thanks to EU legislation on the detoxification of car exhaust by catalytic converters. Nothing to do with suicide prevention, but the effect was a huge reduction in that method. We ask local authorities to tackle one particular method, and that's their physical environment. There's quite good evidence now, so-called hotspots. There's quite good evidence that if you tackle, whether it's multi-storey car parks or sometimes they're railway locations, level crossings and so on, bridges, if you tackle those things with barriers, with helplines, sometimes with patrols, good chaplaincy services around, then you can reduce risk. And that's what local authorities have been asked to do all around the country. But you can also tackle hotspots by encouraging the media not to spread the message, not to make it possible for people who are suicidal to engage in copycat incidents, knowing about an incident, knowing about a location. And it is usually the local media that spread the word about hotspots. How do you deal with the media? Well, this is a slide from the Samaritans. Samaritans are very good at approaching the media. They offer training to journalists. They ask newspapers, when reporting a suicide story, not to talk about in detail about the method, not to make a suicide seem romantic, not to make it seem inevitable. And it isn't just news reporting, it is also drama, and that story of drama has changed. The copycat death first, it is said at least, first started in the 18th century with the publication of Goethe's The Sorrows of Young Werther. And Werther was a character in his book who essentially died as a result of of unrequited love. He died because the woman he loved was unattainable, and so he killed himself. And this had a profound effect across Europe. There were a number of suicides were attributed to reading the book. Lots of people wore the clothes that Werther had worn in the book. It was a very interesting copycat picture. And eventually the book was banned in various parts of Europe, including parts of Italy, parts of what is now Germany, and Denmark. The book was banned. But now, this is 13 reasons why a Netflix drama beamed into people's homes, not from a BBC or from a British TV station, but from outside the country. Therefore, immune to media guidance, immune to British law, coming into our homes, ignoring requests not to depict a suicide method. There was a graphic suicide in one of the episodes, and not to make suicide seem justifiable. There was a revenge motive, a positive, in a sense, perversely positive motive. So, important variations and suicide, important ways in which suicide prevention should vary. This is Emil Durkheim, one of the most famous suicide researchers, died 100 years ago last month. Famous for writing about the social context in which suicide happens. Durkheim died at the age of 59. You can go to his grave in the Montparnasse Cemetery in southern Paris. And these stones on his grave are people who have paid tribute to Durkheim. But you can also pick an argument with Durkheim, because Durkheim inadvertently left a message behind for mental health services that he never really wrote about. And that was that because so many of the causes are social, that there's very little that individuals can do to prevent suicide. And that message has permeated through medical practice for about 100 years since then. So in our work in my research unit, we've set out to try and find what it is about mental health services that can be preventive, what it is that frontline staff can do to reduce suicide risk. And to do that, we collect, as you may know, information on all suicides by patients under mental health care. The database is currently around 35,000 people, an incredible toll of tragedy, and we never forget that each one of these deaths is a tragedy and a devastating event for the families involved. But it does allow us to examine in detail settings where suicide might happen, and also to look at trends year on year. Now, everybody at the moment is talking about mental health being in crisis. You can hardly open a newspaper without seeing mental health in crisis. It is just assumed that mental health is in crisis. But it's been in crisis ever since I started as National Director in 2000. So is it possible to be in crisis constantly for 17 years? Well, maybe it is, maybe it is. When you hear some people's stories, maybe it does sound as if things are very tough out there. And that's bound to be reflected in suicide rates. Except that the suicide rate among patients is going down. It's an incredible thing. So the blue line there, the general population, the patient population rate, and the red line there, an even bigger fall in male patients. And why should that be? Well, tribute to staff, presumably, but why should it be? I think it must be that when the pressure is on staff, that what happens is that people respond. That it's not that we're not in crisis, it's that we've changed the way we respond to crisis. And that staff focus in on the people who are most vulnerable. That staff call on that noblest of medical and health traditions and focus on the most vulnerable at-risk people. What happens? Well, this is a slide showing something that we can do about suicide in clinical practice, about restricting methods. And I want to focus for the purpose of tonight just on this blue line, which is about self-poisoning. Here is the falling rate as a result of antidepressant restriction, and here a remarkable rise a few years ago in self-poisonings as a result of opiate poisoning. People being prescribed opiates, nothing to do with psychiatric conditions, of course, but from chronic pain, itself a risk factor. A major cause, the commonest way in which patients die by self-poisoning. And now, since that people became aware of that, a very commendable fall. So safer prescribing, one way in which we can reduce suicide risk. We can make the physical environment safer, just as we have what we're talking about in the external environment, the internal environment. One of the big success stories of mental health services here, the fall in inpatient suicide over the last, this is showing 10 years or so, but it happened over about 15 years, an 80% fall in suicide as a result of making the wards physically safer. Some of those deaths that were reduced were people who died on the ward, but others, it's almost as if once the staff had picked up the need to improve safety, it affected all patients, all methods, on and off the ward. But, as to say there's always a but, the improvement on inpatient safety has slowed, more effort now needed there, and some of that risk has transferred to a different setting, the crisis team, a place where now twice as many deaths occur as in inpatient care. A third of those deaths are people who've been in crisis teams for less than a week, possibly should have been somewhere else. And then to complete the picture of acute care, there is the post-discharge period. And if you add inpatients, crisis teams, and post-discharge deaths together, it's almost 500 patient deaths a year in these three settings. But the post-discharge period is not a uniform period. It is maximum in the deaths are maximum in the first 2 weeks, and those early deaths are linked to short admissions. They're linked to care plans. There's the evidence that care plans work. Care plans are protective, and they're linked to life events. People who go back to life events have a higher, when they leave wards, have a higher risk of suicide thereafter. Now, in the confidential inquiry, we do something else, and that's that we take patient suicide rates in every trust in the country, and we chart the changes that those trusts make in their services. And we try to complicated analysis, but we try to relate year-on-year changes in the configuration of services to the patient suicide rates before and after those changes were made. And by doing that, you can address patterns across the country. You can see which aspects of a service seem consistently to reduce the suicide rate. And this slide summarises that 5 years of work and a series of studies into one infographic, because that is now the task. Summarise it into an infographic, and you're made. So here is our infographic. So excuse me for no more details, but there's safer wards, there's early follow-up, not admitting people out of area, tackling the comorbidities, crisis teams, because actually when you do them properly, they add to safety. Personalised risk management. Those are the things that every trust in the country should be able to do. Those are the things that Durkheim didn't imagine that services could achieve. And just to make the point even more, when we looked at the trusts that were located in poor areas compared to those that were in the slightly better off areas, these effects were greater in the poor areas. So exactly the opposite of what Durkheim would have suggested. The impact of mental health services is greater when the social adversity is also greater. Okay, so where does that leave risk assessment? Risk assessment is very controversial in clinical practice, and I have very strong feelings about it. And the language of risk is everywhere. We can hardly escape from people talking about our territory of risk assessment. A couple of years ago, it was a few years ago now, I was in San Diego Zoo with my family, so my family was much younger there, and we were just walking along, minding our own business, famous zoo, and a 3-year-old, a young child, ran over to us, looked like they were 3. They ran over to us, and they took a plastic fork, and they prodded it into my wife's leg. There were no injuries, no humans were hurt in the making of this anecdote. And the mother ran over to us and said, not to us but to the child, "Did you risk assess that situation before you did that?" Now I knew for a fact that he hadn't risk assessed. But it tells the problem. Risk assessment is everywhere. The language of risk assessment is everywhere. But what do we mean by risk assessment? And do we mean different things? Well, I think we mean different things because sometimes what we mean is risk in the sense of danger, the thing we want to prevent, the adverse event. So in this case, being a danger to yourself, the suicide, the risk. Sometimes we mean uncertainty, so risk in the sense of financial risk. So the NHS is spending money and it doesn't know where that money is coming from. That's risk. That's financial risk. And sometimes we mean probability. So if you're a man and you reach the age of, a male and you reach the age of 15, you have a 1 in 50 chance of dying by the time you are 40. That's the probability. And the main reason is suicide. So that's probability. So we have different ways of defining risk, and sometimes the confusion of those methods, the thing we want to prevent, the uncertainty, and the probability, the statistical probability, get in each other's way and make risk assessment confusing. Oh, sorry. So this is a slide in which, in the confidential inquiry, where we asked clinicians, what did you make of risk at the last time you saw the patient, the last time before they died? And remember that in 50% of cases, this is less than a week before the person died. And mostly they say, so look at this left-hand pie, they say either there was low risk or there was no risk. That's overwhelmingly what they say. And sometimes in clinical practice, we take findings like this, and we say that they prove that risk assessment is a waste of time. It must mean that we're not very good at risk assessment, that we can't predict the people who are going to die by suicide. And as a result, we become reluctant as a profession. We start to back away from the notion of risk, as I think you can see happening now. We back away from it, and we prefer to talk in euphemisms about safety. For example, I do it myself. My own research unit is called the Centre for Mental Health and Safety. But it's not a new euphemism. Robespierre's power base was the Committee of Public Safety. So safety is not a new euphemism. Or we start talking about positive risk-taking, making a virtue of the uncertainty. But honestly, would you fly with an airline that boasted of positive risk-taking? So, we don't know what to do about our risk assessment, and we turn away from risk assessment instruments. And here, of course, we're on strong ground. Risk assessment instruments, that plague of medical practice, plenty of evidence that they contribute little, some evidence that they can be harmful. Not surprising. Risk is not a number. Risk assessment is never a checklist. But one thing this slide is telling us is that if we want to make big inroads into the number of patients who die, we have to prevent suicide in these two groups. The people who we think are low risk. And of course, they're not really low risk. They're just seen as low risk at the time. They look like they might be low risk imminently. And how do you do that? How do you prevent suicide in the low risk people? Well, there is only one way, and that is to build safety into the system, improving care for people, for all people, on the grounds that the vulnerable patients will be disproportionately protected, whether it's by safer wards or early follow-up or by substance misuse services. Now, one of the main successes in public safety in recent years has been in the car industry. It's a fascinating story of how car road deaths have been reduced, greatly reduced, a heroic achievement through a combination of seat belts and airbags and side impact bars. But you could say that what the car industry has done is make it safer to crash. Because that's what all those measures are about. And what's really required is to make it safer to drive. And that is to build safety into the system. Urban speed limits, reduced alcohol limits, that makes it safer to drive. And any further progress will depend on that. And what we've done, I suspect, is make it safer to crash in mental health care. Look at how few people are thought of as being high risk before a death occurs. So there's no point in trying to focus on just that group anymore. We already focus on them. But there's very little further gain, because the maximum gain is 2%. We have to get at these low-risk, so-called low-risk people. So I would suggest, on the contrary, we think we're not very good at risk assessment. I think we're very good at it, really good at it. It's a core clinical skill. We're almost too good at it, and it means that people who are known to be high risk are mainly protected. It's the other people that we need to now do more for. So what do we mean? What is risk assessment then for? What in the end is it for? Well, this is a story of, you may know it's, this is the earthquake in Italy in 2009 in the town of L'Aquila, where it was a tragic earthquake, over 300 people were killed. But what then happened was the seismologists who failed to predict the earthquake were jailed for manslaughter and for failing to predict the earthquake. And subsequently their convictions were overturned, but for a while they were going to be imprisoned because of public anger over their inability to predict an earthquake. And we are in danger of talking the same language of prediction. We are in danger in mental health of talking about prediction, when in fact the task when we are faced with patients is not prediction, but the task is the proportionate response. Can we weigh up the things that might put somebody at risk and balance them with what might protect them? A simple risk factor, protective factor model. Building safety into the system and not focusing on only those who we think could be at high risk. Prediction doesn't work. Building safety into the system, that's what works. Now, I want to talk for the final part of my talk about young people. We get used to big numbers in the media at the moment. Everything is in trillions, national debt, astronomical distances. So it's easy not to realise how big the problem of teenage suicide is in this country, because it's only 150 people per year. But there's commendable government interest in this problem at the moment. The government has become concerned about young people's mental health and by extension young people's suicide, even though they are the group at lowest demographic risk. And this is a big change, I can tell you. It's been very difficult to animate the government previously. Previously, when we wanted to bring out, there was a time when we tried to bring out a report in December, and we were prevented by the government because they said, it's too depressing. Nobody wants to hear about suicide at Christmas. This is true. They actually said that. So that has changed, and that's very welcome. And we've been conducting a national study of suicide among teenagers, where we've collected information on every death through coroners and other official reports, and looked at the circumstances, the antecedents, the patterns, the themes of what happens to people, young people, just before they die. And there's some consistency. Many of the deaths are linked to bereavement, surprising number, bereavement in a young person's life. Sometimes suicide bereavement, a parent or a friend. They're isolated. It isn't just an older person's problem. They can be victims of bullying. They can be physically ill, but not very ill, but sometimes enough to lead to social withdrawal and embarrassment. And what comes out of this is a pattern of cumulative risk. The idea that people carry risk throughout their lives, from family discord, from childhood abuse, into their teenage years, where they face drugs and bullying. And then finally there's another event, and it's often a relationship breakup, or sometimes it's an exam stress. Some of our deaths were actually on the day of an exam, and then the death occurs, this pattern of cumulative risk. So suicide is complex, suicide in young people is complex, and some of those young people are using the internet in a way which is relevant to suicide, but almost a quarter. Searching for methods, usually a method detail, sometimes posting suicidal messages on social media, and sometimes the bullying is online. And this has led our public discussion of this case, the media discussion, to blame social media for the problem of suicide and the problem of mental health in young people. I find that very difficult to buy. Social media, thanks for mentioning it earlier, social media, a tremendous sort of sea of sentimentality in social media, an unlimited supply of virtual hugs from total strangers. Now, of course, there are some bad things that happen on social media. There are some bad things, but I've also seen it as a supportive environment where vulnerable people find a community of support. It's a convenient message, a convenient solution, social media, rather than all the other causes, the bereavement, the isolation, the academic stresses that we really need to focus on. Now, many of the young people are in contact with some sort of child service, but quite a large minority are not, and the key service is their self-harm service. In Manchester, we measure self-harm rates in a project called the MASH project, 20 years old yesterday. I was at the anniversary. And the MASH project has got a number of important findings. This is just one slide showing the demographic profile of self-harm. First of all, showing the high rates in young people, of course. They're even higher in young black girls. The ethnic minority issue, which most of us associate with South Asian young women, is actually a problem of young black women in this country. Secondly, there is a high risk among people who self-harm, of course. If you go to casualty with an episode of self-harm, your risk of dying in the next year is increased 50-fold. And the key intermediate factor is alcohol. But there is an important indication of who might be at risk, and that's people who arrive at casualty having cut themselves. Now, one of the things we believe about suicide is that cutting is a trivial method. It doesn't identify suicide risk. The opposite is true. Cutting predicts suicide in people who go to hospital. Now, these are hospital figures. Community figures are even greater. There's frightening figures about 25% of young girls saying that they've self-harmed at some time. And it's always very difficult to know, are we talking about a reporting issue, or are we talking about a genuine problem of young people's mental distress? The media love the idea that young people are in mental distress for some reason. I think it's very unlikely that the problem is as bad as people say it is. But I also think that it's very unlikely to be explained away by better reporting. And here's why. This is what's happened to the actual suicide rate in young people. Suicide rate in all people there rising in the last few years. So much more credible rise in self-harm if the suicide rate is also going up, and it is. But look, it's gone up to the level it was at 15 years ago. It hasn't reached unusual proportions, at least not yet. So we should be worried about young people's mental health, but we shouldn't be in a moral panic about young people's mental health. There are clear things that we can do about it. Now, in this study, we've been trying to tackle something which has hung around my career for a long time, and that is the question of whether suicide happens out of the blue. For a long time, families have said to me that they, and some of the I know a lot of families who've had suicide in a loved one, and I'm always struck by their phenomenal commitment to get to the bottom of why suicide occurs. But there is a consistent message from some of them about suicide happening out of the blue. And most of us, of course, in mental health research, we've been superior about this for so many years. What they really mean is that nobody spotted the warning signs. And so in this study, we decided to look to see whether there were people whose suicide seemed to happen out of the blue. And the answer is that 1/3 of the young people who died had never reported to anybody any suicidal ideas. Most of those people had never had any contact with any kind of supportive services. And they also had low rates of most of the common risk factors for suicide. Now, it's not exactly out of the blue, but it is more or less without warning. And what those families have been telling us for decades is right. There are people whose deaths are more or less out of the blue. And this is a slide which circulated on social media. This is not actually a child, this is obviously an adult. And you may know that this is Chester Bennington, who is was the singer of the rock group Linkin Park. And he killed himself in July. And 6 days earlier, this photograph was taken, where he took part in a carpool karaoke, and he was laughing, talking about the future, obviously in a good mood, quite sociable, no evidence of depression at all. And it did the rounds on social media. Lots of people talked about it. And the general conclusion was that it's an evidence of masked depression. The self-fulfillment that's intrinsic to psychiatry. The depression's there really, but it's masked depression. I would just suggest to you that there's an alternative explanation, and that is he wasn't depressed at all. He didn't have masked depression. And maybe like some of those young people whose deaths occur out of the blue, they don't have depression. We assume that the final common pathway is depression, but maybe our notion of depression and its link to suicide risk is wrong. Maybe some of the suicides that happen are really evidence of the rapid deterioration in some people's mood, the sudden onset of self-destructive impulses, and combining that with an impulsive male Y chromosome, a death that might not have happened. No wonder risk assessment is so difficult if that's what we're trying to prevent. So my last couple of minutes now. I want to finish now, and I've talked, I hope it's been obvious, I've talked about a number of things which we believe about suicide, which aren't really true. I've talked about risk in doctors, risk in soldiers, I've talked about Durkheim, I've talked also about cutting, talked about talking. So a lot of things about suicide risk that aren't really true. And I want to end by referring to something that doesn't need to be true. A couple of years ago, again, inspired by some of the families that I met, I set out to broker a consensus statement on disclosure of suicide risk by clinicians to families when they were worried about a patient. A very strong feeling amongst families that we are sometimes too protective of confidentiality and we don't take families into our confidence when we should. Not just psychiatrists, but health professionals in general. And it took about 2 years to get the professional consensus on this. 2 years of discussion with the Royal Colleges, and with the GMC, and with the Department of Health's lawyers. It took about 2 years. And that was because what came across was that outside those families, there was this sense that, it's hard to say this without saying it starkly, that people felt that there was a professional intrusion here. That sense that we should prevent the suicide, that we should overturn a person's decision-making, that was somehow, we were in a grey area of our professional competence, our professional duty. That suicide maybe was an example of self-determination, maybe a choice, maybe even a right. And that came across very strong. That's why it took 2 years. And so our task in mental health is to redesign what we mean by patient safety so that it matches an era in which patient autonomy is to the fore. A lot of good reasons why patient autonomy is to the fore. But we need to get that balance of capacity, a legal concept, after all, a legal concept, and incidentally, a checklist, capacity with what matters in our tradition, and that is social responsibility, the best tradition of healthcare. Not one overshadowing another, not the assumption that one will always trump the other, but a balance of those two things. This is our hard-won esteem with the public. The first part of this slide is Suicide of the Countess by Hogarth. And you see it's meant to be a comical slide. The unfortunate Countess, depending on who you believe, the figure on the left there is the doctor confirming death by feeling her pulse, but at the same time stealing her jewellery. So that's how doctors were viewed in the 18th century. On the other part of the slide, there is the Ipsos Mori poll, the so-called veracity index. Which professions, the public are asked, do you trust most? And at the top, every year, at the top are doctors, or at least we were until they brought in nurses. Nobody, but nobody, can out-trust nurses. How did that change happen? Well, over the years, something has happened about the way the public view us. And I would just put it to you that what has happened is that we have, as a profession, more and more embodied society's best values. We represent what the public want to happen to them and to their loved ones. And we mustn't lose that by getting the story wrong on capacity. So it's our job to represent society's best values. And it means being honest about what causes suicide, the social conditions, the economic adversity. It means providing services in a way that's, first of all, about keeping people safe, our #1 priority. And even in an era in which the individual is king and choice has become a virtue in its own right, it also means social responsibility towards the people we are responsible for, our most vulnerable citizens. Thanks very much for listening.
proceed with road design. And then, as we know, the Dutch are very good at this kind of thing, and they like to build in forgiveness to their road layouts, which means if drivers make a mistake, or cyclists never make mistakes, obviously, but if occasionally a driver makes a mistake, it doesn't matter because the road layout enables that mistake to be forgiven so that it won't prove fatal, or if there is a crash it won't be fatal, maybe there won't be a crash at all. Can we aim to do something similar in mental health in relation to suicide? Are there any examples of this kind of principle being designed in?
Well, I suppose it's the nearest thing is the principle of candour, which has become popular. So, in fact, it's a duty of candour, which has been brought into the health service. But it will be very hard to have a duty of candour unless you also have what you're describing, which is at least a high level of tolerance of what people might feel is otherwise they're culpable for. I do think that you've hit on an important point. I'm sorry I didn't have more time to talk about it, but I think what's implicit in what I'm saying about risk is that it will always be difficult to make the judgment. So we will always be dealing with that combination of probability and uncertainty. But they're not the same. There's real uncertainty and there's genuine probability, and we can use both. And if you bring them together, what that means, if you use them sensibly together, that is, then it means that you have to plan for error, because there's a certain amount that you know that is about probability. So you can say, well, I know that this person is at this level of risk, and you can refine it. The research evidence is there. We can refine probability more and more tightly, but it still leaves in people's complex lives that element of uncertainty, and the only way we can address that is to plan for error. So I mean, I would like to see the NHS. That would be not positive risk taking. I would think the slogan we should have in the NHS is, the NHS, we plan for error. We make mistakes. That would be a really good slogan for the NHS, because it would be honest. And what it means is the kind of thing that you're referring to, which is the safety net. So it always worries me when there's an inquiry or something and people say, what we're going to do is make sure that this never happens again. Because you just know that it's going to happen again. Maybe not exactly the same way, but something equivalent is going to happen again. And we need to be more honest and say that, that not everything is preventable and predictable, that we build a system where we expect something to go wrong, and what really matters is what's tripped by that error.
Thank you very much for the talk. I have two linked questions. So regarding your slides on risk assessment, could it be argued that the percentage of people exposed at high risks are the ones that hopefully have been intervened with and therefore don't show up in the sort of the flip side of the graph? So first of all, is there evidence for that? Is that something that's been explored? And related to that, if there have been intervened, whether there is some specific practice related to that can be generalized to the others. Yes,
well, I think that's right. I think that is. I don't think that's a fanciful explanation of the findings. So, why is it that so many people are said to be low risk or even no risk? It's not because they really are. So what we're asking people is, how did they view the imminent risk at the time? So it's the immediate risk. And I think, and what we're seeing is that very few people, having been seen as high immediate risk, then go on to die, because the system snaps into action. Something happens. It's a dynamic system. You make a change. But the argument, and so when people talk about, I did a risk assessment and the person was high risk, I cringe at that because the assessment is never going to give you the differentiation that you might need. The message of that slide is that we've been quite good, I suspect, at identifying high risk and doing something about it. We're pretty good at building risk assessment into what we do, not because we fill in a form, but because the minute somebody walks into a room, we're starting to think about the risk. It's the inherent in the clinical process. And we sometimes, I think, misrepresent even to ourselves the nature of the task. The task is the proportionate response. The task of those poor seismologists in Italy was the proportionate response. So they were right not to predict an earthquake. because it was unlikely. But it could have happened, and they didn't say it couldn't. Actually, I think one person said it could. But in general, the requirement here is the proportionate response. And one of the first papers I wrote about suicide prevention was about the balance of risk and protection, and I still think that is the right question for us. How much risk is there? Not is it low, medium, or high, and not I can't do this, it's too difficult, we can't predict. We're not being asked to predict. What we're being asked to do is prepare a plan that is proportionate to what the patient is telling us. And if somebody's isolated, do something about isolation.
You told me something I didn't know about the 30% of suicides, mainly men, who haven't seen their GP, I think, in a year before they kill themselves. Do we know anything about I think it's up to 30% of people who kill themselves who have seen somebody in primary care during the week before their death?
Yes, well, there are quite a few figures around about primary care. Our study was slightly different. So they roughly divide into three groups of people. This is a little bit crude. There are people who are in contact with mental health services, and that's going up. That's part of the pressure story, actually, because it's not the resources, it's the number of people who are in the service. And that's about 30%. And then there's roughly another 30% who are in primary care but not in specialist mental health care. And then there's the group I referred to, which is the group who are not anywhere. The middle group, people who are in primary care, they've been in contact with primary care. We looked at the final year before they died, but you're right, there is a kind of crescendo effect. People attend, and their attendances get more frequent as the time approaches. But taking that group as a whole, they are people who they tend to have a mental health history, but not always. They are often presenting with a mental health problem, but not always. And that's the problem. But they're, you feel sorry for GPs sometimes. We ask them to do more on suicide prevention, and they say, well, who? And so all we can offer them is markers. And one of the markers, of course, is mental health problems. Another is frequency of attendance. By the time somebody has attended on average twice a week, they are at 12 times the risk of the general population. Attended primary care twice. So I say twice a week, twice a month. Some markers, so we know a little bit about them, but it only takes us so far, I think it's honest to say.
Thanks very much.
Is there any relationship at all to suicide rates and the availability and number of psychiatrists in a given area? That's the first question.
Right. Well, yes, there is a relationship, and it is that suicide rates tend to be higher where there are more psychiatrists. I think we can dismiss that as a causal connection. But it's probably for historical reasons that you get more psychiatrists in certain parts of the country, and they're often parts of the country where there's an urban environment, the hospitals are set in the city, and so on. So, and the same is true of resources. If the government ever get the idea that more resources are correlate with higher suicide.
The other point is, fortunately, most people who have quite intense suicidal ideas and are very depressed don't commit suicide, fortunately. And what about the factors that protect people? Is there any sort of systematic study looking at those? So many people I see are very worrying, and one of the questions I was asking, what actually is stopping you from killing yourself? And I wonder, is there any systematic studies into that phenomenon?
There are some. Perhaps I could just complete my previous answer. There is one feature of staffing which is important, and that is staff turnover. So in that slide, that infographic slide where I summarised 5 years ago, one of the points there is that places that have high staff turnover tend to have high suicide rates. Now, you can't be certain that's causal, but obviously there is a plausible causal case there. On the protective factors is actually a very good question. Why don't some people take their lives when they're in such desperate difficulties? And there is a little bit of research. I suppose one reason is religion. People get it. Another is fear of the act itself. So pain, discomfort, and so on. And another is impact on the family. So So I wouldn't do it to my family. And very often impact on my children. I wouldn't want my children to know that. And so there is this very important protective factor about the environment in which the person is living, the relationships which sustain them, even in the most difficult times, and the awareness of trauma, the traumatic impact. And what it means, I think, is that when a patient says, my family would be better off without me, that's the time to really start worrying.
Sorry. I was very struck indeed by your first or second slide because it seemed to show a horizontal band of relatively low risk in the countries that are Middle Eastern across to Southeast Asia. And that, and you mentioned at the very tail end there, led me to wonder to what extent there is actually a major input of religion. And has anybody undertaken any studies to actually look at this? I mean, I remember looking at conditions in India and the incredible contrast between the conditions of so many people and yet their very, very optimistic attitude to it all. And so it really left me with a very strong feeling that there must be something to discover there, and a bit of comparative analysis might well pay off quite a lot of dividends.
Well, it's an important point, but it's quite hard to disentangle latitude, as you rightly pointed out, with some of the characteristics of the countries in that zone, because some of them have as a state religion, a religion that they may be Muslim countries, sometimes Catholic countries, where there's a greater taboo about suicide, and that not only makes suicide less likely, but it also makes the recording of suicide less likely. So the rates become less reliable, the official rates become less likely. Sometimes developing countries have rather poorer statistical reporting systems, so they rely on the police or some other judicial authority to determine suicide, and that means that the threshold is raised. So cases that might be recorded in this country, even under ambiguous circumstances, will not get recorded. So it's quite hard to disentangle. And of course then there is alcohol. Alcohol, a major contributor to suicide rates. Probably one of the reasons why Eastern European countries have such high rates, the alcohol. And of course some of the countries we're talking about have low alcohol consumption. But there are some very interesting international stories in it. And my point was that there isn't one story here. There are quite a few stories about why suicide happens. Look at South Korea with its intense work culture and educational culture, one of the highest rates in the world, but quite a well-off country. Look at Sri Lanka, this incredible story of one of the highest rates in the world, greatly reduced by restriction on the use of pesticides. So the availability of a method driving up the population rate. And then Lithuania and some of the other countries like Belarus, very high rates, particularly in elderly people, particularly linked to alcohol, and I suppose to relatively poor mental health services.
I'd like to ask about suicide in the medical profession, and if you're looking at that as a special interest case. Having come from an acute specialty like anaesthesia, where we're well aware of quite a high suicide rate in relation to deaths on the table, unexpected deaths, errors, etc. What are your views on this?
Suicide rate in doctors was one of my things that people believe are high, but the suicide in this country at the moment, doctors do not have a high suicide rate, and male doctors actually have a low suicide rate. But it's important to qualify that, I must say. First of all, there are something like 16 deaths a year among doctors, and that may not sound a huge number, so the problem with big numbers are related, but it is a big number. Any number is a big number. And 16 deaths among working members of our profession, that is a tragedy. And so the need to prevent those 16 deaths is not just an issue of whether the rate is high or not. It's to understand the circumstances, and I suppose that the NHS should have its own safety in order before it pontificates about other sectors. So the story is a mixed one, I think, about doctors. Bear in mind, by the way, that nurses, female nurses, do actually have a high suicide rate. So there is a contrast here. Why should doctors? I mean, the point, I suppose, is that doctors don't carry most of the risk factors for suicide. On the whole, they're not poor. You know, on the whole, they're living in a supportive environment, whether family or work. They're mostly not. I don't know why people are. They're mostly not drink. They're mostly not drinking. But you know, some of the main risk.
We are going to be drinking soon.
Some of the main risk factors are so they may happen in some doctors, but in general, doctors are a low risk factor group, and so you wouldn't necessarily expect high rates in doctors. So when I say the rates aren't high, you know, the question back has got to be, okay, taking into account the rates of all the risk factors, are they high? And that I think we don't really know. Personally, I think it's time for a national study of what's happening to doctors. Maybe it's gone down, because when my friend, colleague Keith Horton did a study 20 years ago on doctors, that was because everyone believed that the rate in doctors was high. But it was the proportionate mortality rate that was high. It was because doctors weren't dying of anything else. But suicide looked high. It wasn't really.
Question? Yes,
They'll bring your microphone. There's one coming.
Thank you for the great talk. I'm wondering if you could say something about the high rates of suicide in people under crisis teams and explain that phenomenon a little bit more deeply, please.
What's happened in crisis teams, I think, is a very important illustration about the way services change. So that when crisis teams came in the mid part of the last decade, it happened over quite a short period of time, and so that suddenly there were far more people were under crisis teams than had been before. And so inevitably, the number of deaths under crisis teams, I'm sorry that it's inevitable, but it is, that the number of deaths went up under crisis teams. That in itself wasn't then the issue. The more important thing was that the next period of time, so once it reached a plateau, that happened in a way that meant that the risk in crisis teams was greater than the risk in inpatient care. Now, if you think of the risk protection model here, what's special about inpatient care? The greater protection. What's special about crisis teams? It allows people at a certain level of risk to be looked after without the same level of protection. And the problem was that it looked as if, so you'd expect that if you got this system working perfectly, you would have suicide rates which were the same in inpatient care and crisis teams, because the risk protection balance would be correct in both places. What we actually saw was that the risk in crisis teams was higher. And that had to mean that either the protection wasn't as good as we thought, or that people were going there who weren't ready for crisis teams. It had become the default option for too many acutely ill people. And so that was our fear, and the fact that a third of those deaths happened within a week of coming under a crisis team suggested that was the explanation. But to be fair to crisis teams, what's happened since then is that the rate, so the numbers have stayed more or less stable, but the rate has slightly come down. Even the numbers now are beginning to come down. So we are seeing what looks like an improvement in safety in crisis services. And what it doesn't mean is that crisis teams are somehow inherently unsafe, because in that complex study that I summarised, one of the innovations that led to a drop in patient suicide was bringing a crisis team in. But it wasn't just any crisis team, it had to be a 24-hour crisis team, properly funded, properly staffed. It had to be, and if you do things properly, you get the benefit. If you don't, you run a risk.
We've run out of time, and I actually think that's a lovely note to finish on. So thank you very, very much.